So we'll hear three different perspectives of leading pay setters in the innovation space of employee benefits, and just it's a good way to start it off, because what they'll talk about should interest all of us before we go into breakout sessions. A couple of comments about that. I mentioned about the increase in costs of care, and it's no surprise to the employers. So they've been contending with this and trying all kinds of different strategies, and there's a whole bunch of new strategies that are in the works right now, and some are having extreme success. For example, direct contracting. We'll have a session on that, a whole slew of different sessions and different aspects of direct contracting with narrow, high-performance provider networks and centers of excellence. Many companies have gone into the high deductible plans, which have lower premiums for their employees and for the employer, and put in the health savings accounts with that. And that's very helpful for the employees, but in fact, they are not as well adopted by the employees as the companies would hope. So often they'll offer us another plan along with it. There are only a few that I've heard of that offer that as the sole option. On-site nearside clinics. This is really a growing trend, and contracting with retail clinics is really big. Contracting with accountable care organizations, primary medical homes, that some of the larger companies are doing. That's where they share the risk with the accountable care organizations. Some are doing that, and we'll hear a little bit about that here. And then Navigator Service, a big, huge growing trend because employees are still so confused and it's so complicated to try to figure out where to go and try to get the best care at the right time and at the right cost. So a lot of companies are hiring or building in-house Navigator services, concierge services. So those are just a few of some of the new ideas. Walmart, of course, has been this year's poster child of value-driven benefits. They're trying almost all of these different strategies that I just mentioned and tactics. So we'll keep an eye on what they're doing. But the big deal is that they have the leverage to do the things that they're doing, and I think sometimes that's what it takes to do so. So let's start with you, Jason, if you don't mind. Can you tell us about some of the innovative things that you're doing? What's ahead? And how is Boeing approaching all this?
Sure, yeah. First, I just want to thank you for the invite, and it's a privilege to be here. Just to give you a quick high level on what Boeing has done in recent years around value-based contracting and really, I'd say, driving waste out of the system. First and foremost, we have had, since 2015, really the start of our journey with direct contracted ACOs across the United States. So today we have 4 different critical mass markets where we have a considerable number of Boeing members that are covered under our benefits. And I would just tell you candidly, for us, based on our actuarial assessments, we really needed about 5,000 employees or more to justify our effort to go down the path to do a direct contract with a health system in a given market. And luckily, we've had Puget Sound, Southern California, St. Louis, Missouri, and Charleston, South Carolina, where we've had way more than 5,000 employees. And we've had a willing, I would say, audience of medical systems willing to take risk, play ball with us to basically address the triple aim framework, which is all predicated on improving affordability, reducing costs, improving an optimal patient experience. And thirdly, it's really all around quality outcomes. So with that, we rolled out Puget Sound in 2015, St. Louis and SoCal and Charleston in subsequent years in 16 and 17. And each year what we've seen through these direct contracting arrangements was a couple of things. One, we maintain employee choice, so we did not do any reimbursement. We're all about allowing our members to have choice. So in many cases they have an option to enroll into a PPO plan, a high deductible health plan with an employer-funded HSA contribution, an ACO option that has both of those medical plan options. And then in some cases, they might have a fully insured HMO or an EPO as other options. But over time, what we've seen is a continued uptick in enrollment into those plan options in all of those markets each year, and really good member experience feedback as well, which is key because the members have a choice. They don't have to re-enroll following, open enrollment years. But that's really played well, and it's also, I would say, extracted waste out of the system by which the ACOs are really bearing financial risk to deliver better outcomes. Thanks.
Okay, that's very interesting. We'll come back to some other questions to probe a little bit more on what you've just been telling us about what Boeing is doing. So, Riddhi, you're doing some very innovative things too, but when we had our prep talk, you felt like you may not be, or you might be falling behind a little bit, but in my opinion, and from what I've read about what AT&T is doing, you're one of the pace setters for sure. So can you tell us a little bit about the innovations and what you have thinking about ahead for value-driven care?
I might first start by level setting what we did maybe like 13 years ago. We moved to full HDHP plans for our managers. So half of our employees are management, half are bargained. So we have 100,000 managers spread out all over the nation, and that's the population we can really impact due to the union negotiations. And so we went to full HDHP plan replacements 13 years ago. And at the time, it felt like the right thing to do from a cost containment perspective. And these days, it's getting a little bit of a bad rap. Like, we are that one employer that doesn't offer kind of a PPO type plan. But what we did find in doing that is that there are people that benefit from that. So if you are a healthy, younger person, there's value in moving to a higher deductible health plan, growing your HSA, saving that money for future healthcare expenses. But we do want to have that meaningful design. So, and one more thing with the high deductible health plans is that it actually exposed a lot of waste and fraud in the system. So once you made that participant the consumer of their own healthcare, they were aware of all of the egregious pricing that was happening, right? If you're paying $10 for a copay, you're not going to see that pharmacy costs are going up every single year. And so it has, in a way, impacted our healthcare ecosystem and environment to, and even legislation to kind of drive some key changes that are needed. But going back to the member, at this point, we have, 3 high deductible health plans that we offer with varying deductibles, and the lowest deductible health plan really isn't that meaningful for our employees anymore. We have some HSA seed in our higher deductible health plans, and so one of the things that we want to focus on is kind of providing that meaningful plan choice, but in a way that, be it via kind of a high-performing network, which we don't have today, or adding some sort of concierge service on top, because navigating the healthcare system is the hard part. And what we have been reading about and want to focus on is creating that relationship with our members and primary care physicians. So roughly half of our members today are going to a primary care physician. We think it should be higher. So we're trying to look and take steps towards that. One of the things we are opening in 2020 is in our downtown Dallas area is an on-site clinic, which will have kind of that lower access to care, $35 for an office visit. We'll be on site, open to our employees, and will hopefully help them kind of build that relationship with their primary care physician. It is a primary care medical home or patient-centered medical home model. And we think that when you do have that relationship, we can control from the bottom up, i.e. the doctors can control where our members are going. So for us, that relationship might help steerage towards maybe higher quality specialists and facilities in the future.
Okay, that's great. I told you were a pace setter. All you're doing. Tom, what about the Boots Alliance and the retail clinic space and your challenges and your new ideas? What do you try?
Yeah, so as many of you might know, Walgreens Boots Alliance is the parent company of Walgreens. Pretty big company, 220,000 members in our health plan. If any of you know me, I've been pretty much a disruptor. We were the first large employer to go to a private exchange. It failed, and 2 years later we went to a self-insured private exchange. But my basic focus the last few years has been really to change the dialogue. I think we have done a disservice by saying to our employees, here's a deductible plan, go be a consumer. You can't be a consumer in a non-consumer market. It isn't a consumer. We're fooling ourselves if we believe that healthcare is a consumer market. A consumer market is one where you can walk into a store like Best Buy and you can look up TVs. You can spend hours and hours. And in fact, research shows that people spend hours and hours researching buying a TV, buying shoes, buying a car, buying a home. But we don't spend any time searching for healthcare because you can't. It's not the same as buying a TV. It's almost like going into the Best Buy. I've used this example if you've heard me before. And giving the kid the wallet and saying, hey kid, go get me a TV. And the kid, who could be the doctor, goes in the back of the room, pulls out a TV, swipes your credit card, puts it in your car. You get home, you find out the TV is only 40 inches. It's not Ultra HD, it can't connect to the internet, and it doesn't have the right plug to go into the wall because it's a European TV. That's healthcare today because the axis of control is in the wrong place. The axis of control in this country is with the doctor. And yet we've built all these wonderful networks and all this consumer design in our 170 million employees who have access to care to be a consumer. And yet they go to the doctor, and the doctor takes our wallet, and the doctor says, I want you to go to Joe's MRI to have your MRI tomorrow. Joe's MRI is not in our network. In fact, Joe's MRI is the most expensive MRI in our network. Doctor didn't know that. Why would we give that control to that doctor? I love doctors, but they should care for the patient. And I've been trying to change the dialogue. We don't have consumers in our health plans. We have patients. We have potential patients in our health plan, and we should treat them like patients. And so our focus at Walgreens over the last 3 years, 4 years with our partners, Blue Cross and United, has been to focus on coordinating that care for the member. In fact, our card is, if you look at the back of your card, it's probably the most confusing benefit card you'll ever find. There's probably 7 numbers on there, nurse line, this line, this line, nothing that's instructive at all. Members get confused. There's one number and there's one sentence. All care must be prior authorized. The care then is prior authorized with the provider. Sometimes the patient team member doesn't even know that it's going on. And we have care coordinators or navigators at the 2 carriers that direct almost all of that care. Get people to the right place at the right time for the right cost, for the right quality. That's the goal. If we can control the delivery of care, we can control the cost of care. So Walgreens, over the last 3 years, has bent the trend. We've had negative trend 3 years in a row. So we've beat trend by close to 7%. Trend's about 5% in retail, and we've bent the trend by 2% below our budget for 2 years in a row without cutting benefits, without adding more cost. In fact, in 2020, we're going to be lowering our deductible. We're going to be adding a pharmacy benefit that no one has to spend more than $30 for any drug in 3 tiers, $5, $15, and $30. That's it. Because we've been able to control the delivery of care, and we've started to treat our employees like patients or potential patients and not like consumers in a non-consumer market. So that's my thing. And then we give them access to all the wonderful things we have with clinics. You know, we have clinics around the country, $5 copay to see the clinics, $5 copay for telemedicine for behavioral health, dermatology, and chronic care. So we give a lot of access to people. And then we have a lot of tools and resources around disease management for musculoskeletal disease, with Hinge and others, and with diabetes with a partnership with Onduo. So we have a wealth of resources that we provide our members for free that give them access to a lot of tools and resources as a patient.
Wow, pretty comprehensive. Well, I guess the big question is, you're offering all of these different innovative ideas or strategies and tactics that you're putting in place for the employees. And Tom, you're so right. Employees are not consumers. We keep talking about consumer-directed health. I don't see that happening anytime soon. It's not like buying a TV then, or the wrong TV. But how do you measure value? I mean, you've got all these different programs, Tom, and you too, Jason, and you as well, Riddhi. How do you know that you can measure the costs? That's the easy one. But what about the other aspects of value? That would be, for example, the getting the right care, getting the good outcomes. And somebody who has knee surgery, the good outcome is they walk out of the surgery and the job was done, it was done correctly. Well, What if the patient still has pain and is suffering from depression and all these other things? Is that a good outcome? And having trouble going to work, that's not a good outcome. So how do you determine value? Do you want to talk about that, Jason?
Yeah, I'll take a shot at value. So, what is value? Value is quality over cost. And what we've done with our direct contracted centers of excellence across the U.S., the likes of Mayo and many others, what we've done with our direct contracted ACOs, predicated on the AAA framework, quality, member experience, and obviously cost affordability, we're quantifying the real outcomes on all those different dimensions. And to Tom's point, we're also bending the trend on price inflation as well through these value-based arrangements. So at the end of the day, we're basically putting, I would say, financial risk on the backs of the systems, on the COEs that we have for hips, knees, back, bariatric across the U.S. We're willing to cover 100% of the cost of those high-cost procedures. But at the end of the day, what we're finding is that the majority of the savings that we're deriving from those direct contracted COEs in particular, and I'm sure Olivia Ross from Pacific Business Group on Health will probably touch on this later in the session when she talks, what we're seeing is that we're avoiding a lot of unnecessary procedures in the first place. So there is over-testing, over-medication, over-screening, unnecessary and inappropriate care. We're seeing even across, I would say, complex case diagnosis that our members are taking full advantage of getting a free expert second opinion and a treatment decision support. 37% now, we just got our data last week, 37% are either getting an incorrect diagnosis or getting a better clarification on what that diagnosis really is or should be. And nearly 75% of our members are receiving a suboptimal treatment regimen. So they're getting a more optimal, based on their real diagnosis, the real condition, a better treatment pathway forward. And what does that tell us? What that tells us is there's so much variability in quality across the systems. And even if you look at the system in particular, even in DFW, we're seeing a range of OBGYNs delivering C-section rates, best case 14% of the time, worst case 49% of the time. So 1 in 2, deliveries are C-sections through certain doctors in the Metroplex. Why is that? Why is there a 3 to 4x, variability in unnecessary C-sections? And what can we do to better inform and steer our members towards those optimal, high-quality performing doctors and systems and COEs and ACOs that are financially incentivized to do the right thing and drive waste out of the system? But it all goes back to value, and it's such an important topic. And I think through improving data analytics and innovators that are really kind of going after it, even on the imaging side, we're seeing variability in readers within MRIs where there is absolutely incorrect diagnosis being, given to our members just on MRIs alone because there's variability in the quality of the equipment that's being leveraged. And we all know there's huge variability in the cost of the MRIs and imaging to begin with as well. So how can we optimize that and do better around, imaging and ensuring that A, it's necessary, and B, we're steering to a top quality imaging provider that has best-in-class equipment and readers to, hopefully render the appropriate diagnosis. So those are just a number of things that we've been working through and evolving over time.
Riddhi, what about you? How do you, with all of your different programs and innovations that you're doing, how do you determine that you're getting value, and how do you measure your value, other than cost?
Yeah. So I think Tom said it, value kind of comes in getting our members to the right place at the right time and at the right cost and quality. There's actually no silver bullet in trying to find that optimal journey, but maybe 2 things that we're trying to do to get ahead of it, or at least to try to measure it. So one, on the contracting side, so with our vendors, as we launch new solutions, as we continue and expand contracts with our current vendors, I think we try to put clinical-based outcomes within our performance guarantees, as opposed to just having right call center rates and things like that. And so trying to put our vendors to ensure that they're returning that value that they've pitched to us. So when you implement a population health management solution, or even in our on-site clinic, we want to make sure that they're closing gaps in care, that they're engaging with the right participants at the right time, and putting that on our vendors to make sure that they're delivering on that value that they've promised us. So that's one. The other area where we're trying to measure the value is really the data that we're collecting from our vendors as well. So through the data warehouse, ensuring that we're getting the right elements of data so that we can, on the back end, independently verify that we are receiving value, that members are having those, PCP relationships, or are, where we can get clinical information, which can be hard sometimes. That we're able to track, maybe sometimes it's the biometrics. And so can we see that, yes, when someone engaged in this program, their A1C levels went down, if that was the goal of implementing any given program. So those are a couple of ways that we're trying to measure the value. On the back end, Jason said it, the analytics is really important. And so I think we're even thinking about how we make our data warehouse and more useful and optimize all of the information that we sit on.
Tom, would you say that you do similar for your measures of value, aside from the great cost reduction that you've experienced? What are your thoughts about that? Is there some nuances that you can tell us about?
Yeah, it isn't always just about cost, right? I mean, I think we're very focused on cost as as organizations. We're not a revenue generator in benefits. We're a cost center, and it's not fun to walk into a CFO's office and say, I'm happy with a 5% annual increase. Any salesperson who did that would be fired, but we get to do it every year. It's not always about cost. It's about satisfaction and quality and participation and engagement. I think value is a lot more than just cost over quality. It's a lot about you can actually send somebody to the best quality hospital, the best quality provider, but if that provider has a terrible M&M on knee surgery, but they have great quality because they get great scores from their members, why do you want to send them there? In fact, I think what the latest research shows, upward of 60% of knee arthroscopy doesn't need to be done, and yet we pay for it every day. So I think some of it is the mixture of the art of practicing medicine, right? And finding the right place for the right person at the right time, and if it needs to be avoided, finding other services that they can have that help them avoid, right? And help them engage. It's why we put in some of our musculoskeletal programs, because really, if it's easy for them to engage in these programs, they avoid surgery. And that's wonderful. I'd rather have somebody back at work faster, avoiding surgery. And so it's a very challenging paradigm to just look at cost and quality. I would say we also try to look at our data across all the spectrum of data that we have. Looking at disability costs, looking at workers' compensation costs, looking at engagement scores, looking at performance scores, and heck, I'd like to even look at store performance and tie health of our members to store performance. And I think when we're able to do all that in a good data warehouse with good data analytics, we can then prove that the things that we do, the interventions that we do, really have an impact, and really not just on cost, but on the many other ways that people participate in our workforce every single day and are productive for us. And that's, in the end, what we want. We want a productive workforce. So I think that's how we look at the whole milieu.
Well, it's interesting for your approaches and how you all measure value and the value-driven initiatives that you're putting in place. Your employees are captive audience for half their waking hours. So you can do a lot of things that, for example, Riddhi, you only offer the high deductible health plan and have the navigator directing them. So that's great, you have that under control, but what about on the provider side, your experience with the providers? Do you think they're ready for value-driven healthcare? How do you get the control on the other side of the fence? Your partners who are, if they're in a value-driven contract, don't they owe something to you to deliver value? Tom, or, You, Jason, you're nodding your head. You
Yeah.
might have a take on this.
Yeah, I do, and I think it varies based on market. We've often experienced and said to others that we've helped kind of figure out the whole direct contracting ACO pathway around. Being a trailblazer is, if you know one ACO, you know one ACO. Just like if you know one market for healthcare, there's a lot of unique attributes and characteristics to that market. Whether it's Dallas-Fort Worth or Chicago or whatever. So what we tend to see is, luckily for us, we've been very fortunate and privileged to have a willing group of health systems across the market that we've pursued have a willingness to take financial risk and work on, improving quality and reducing waste. But I will tell you, it's not always the case. If you go to certain markets, why would a hospital system want to take on financial risk and make that pivot away from traditional fee-for-service to value-based models if they don't have to? Why would they not want to perpetuate the status quo? So my simple point is, what we're seeing over time, and this is getting proven with relationship-based clinics like Iora Health, who we've done a pilot with in Arizona, and they're crushing it for us. They're not taking 7 or 10 minutes to, have a primary care doc visit with our members. They're taking 1 hour, 2 hours, and they're developing a relationship that's melding behavioral health with physical health, primary care, and it's all outcomes-based and value-driven. So everyone's taken note of players like Iora Health. What Rashika's done there has been amazing for our members in the Arizona market, and we're looking to, expand that elsewhere. But there's other players that are, taking that type of model and bringing that forward, and we're going to see more of that even in this market. So it's going to be interesting to watch that evolution, but I think over time what we're all going to experience is the disruptors, the innovators, the employers, who are really the payers at the end of the day. As Tom mentioned, over 170 million Americans are under employer health care. We're paying the bill, and we don't have to put up with status quo fee-for-service. We can invest in those innovators and in those disruptors who are willing to deliver value and deliver better outcomes, and really, hopefully over time, quantify meaningful trend differential between what the status quo is at that 5% a year versus a negative trend. And that's aspirationally what we try to do every day with our medical strategy, our pharmacy strategy, and so forth. So hopefully that gives you a little perspective.
Yeah, okay. Riddhi, what about you? In your experience, do you think the providers are ready? Are you seeing a gradual change over to sharing in risk and
Yeah, I think Jason said a lot, and one of which is that every market is different. All of the provider groups in a given market are unique and have different goals. I think one of the challenges we see is it's that perverse incentive. So at least when we've had conversations with providers, and not all, but they're trying to play with us to get numbers. So it's a volume game. And so I think for us, it's trying to find those provider groups that want more than just our members, that they actually want to disrupt as well. And I think that has been the challenge, to find people that have the same objectives and goals. Because a lot of, right, if you're a hospital system and you get 5,000 members, well, you're willing to take a cut. And so it feels like they think that we want the financial gains, when the reality is we actually want the better health quality outcomes for our members. And so I think the challenge we're facing is these unique physician groups that actually want the same goals as us, and see the value in, the financial reduction is the outcome or the byproduct. And I think they think we're looking just for that financial gain, and that's hard to find those physician groups that want more than that.
Thanks. In the interest of time, I'm not going to ask the same question of you, Tom, but instead, I'd like to ask you about reimbursement models. There's a lot of discussion about bundled payments, reference-based pricing, shared savings for the providers to start assuming some of the risk, and different models. Do you see evidence of that in the work that you're doing? Are you trying that? And how successful is it proving?
Yeah, so I think we've been challenged as a smaller local retailer, right? Our stores only have 33 members, so we don't have the volume like Jason does to go after so many direct contracts. Reference-based pricing and bundled pricing are challenging when you don't have the size. I think and also I think direct relationships with providers is really hard. I think Walter Cronkite said, all healthcare is local. It really is. And if you think about it that way, and we're a large, organization that's in every single state. We're in some very suburban and rural areas. I can't go to a small healthcare system and say, I have 45 members, give me a deal. It doesn't really work. And so I rely on my carrier partners to help us with that. And where we can get great shared savings with ACOs or narrow network solutions, we've seen much success. I think it's when the provider is willing to do that and put it at the table, and they have the tools and resources to do that shared savings. I think it can be really effective. The challenge too is that a lot of providers don't have the tools. They just don't have the tools that are necessary to manage their own population. And so we have a real problem in America because it is an unbalanced system. It's not the same everywhere. In fact, it can be in Chicago, I think you probably have 15 different systems. And they all do it differently. And then within the systems, you have 10 or 15 different provider networks, and they all do it differently. And so there is really no set standard of care. And when there isn't no set standard of care that everybody follows, it's a lot like the TV with a European plug and an American plug. You plug it in and it doesn't work. So I think it's hard to solve this problem with simple solutions like bundled payments and reference-based pricing and shared savings, because not everybody can do it.
And what about you, Jason? Do you have any of those any payment models in place like that?
Yeah, we have not done any reference-based pricing, but I would say that what we have been able to structure, to some extent, on a bundle payment arrangement is, some of the modeling we've done with our direct contracted centers of excellence for those high-cost procedures, knees, hips, back, bariatric. Those COEs are literally on the hook to do what is appropriate. So they have placed in the rigor to, again, if someone's not, a prime candidate due to high risk for bariatric, they're not going to do the procedure. Same thing with spine. If the individual hasn't gone through a physical therapist program, perhaps a Rosti or someone like that down in the Texas market, that might be another way to kind of steer members towards at least exhausting all those before they actually go through. So, from a bundle payment standpoint, I see a lot of opportunity, I would say, for greater adoption and utilization, because at the end of the day, if you have a bad, knee replacement, because there's a gap in the joint, and procedure wasn't done correctly or appropriately, and you have to go back in within the next 30, 60, 90 days to have it done all over again, why should we bear the cost of that, right? It's just like if you buy a car and you get a lemon, why should you have to endure the cost of the maintenance of that car over time, hence you got the lemon law deal. So, get a new car and have the manufacturer own up to what, they did. They manufactured it just like a doctor, did the knee replacement. But in general, I think there's a lot of opportunity for driving a different mindset, at a greater range across the insurers and carriers to more widely accept. And we're seeing in recent years, I would say, a greater willingness by some of the insurer carriers to cover certain high-cost procedures in a bundle payment, way, but it's clearly not widespread, across, all the majors.
I think in the interest of time, we will be able to take maybe one or two questions from all of you. We're going to have a sharp stop in about 3 minutes. So, any questions from the audience? That's something we didn't cover here? Oh, come on, you guys. You had your coffee. Yeah, that's something.
What things have you seen that may have shocked you or encouraged you
Okay, looks like Jason's going to take that one.
Yeah, just real quick, the one thing that we have seen as far as changing that approach to the patient is, and this is maybe more obvious, and it isn't just us. Sheila at GM, that launched their ACO, and the others, they've basically created what I would call a red carpet, white glove concierge approach model for our members that are in the ACO, so they can receive, a same-day appointment at their convenience as opposed to waiting 3 to 4 weeks to see whatever specialist or doc they need to see. And there's an 800 number, and there's an embedded patient-centered medical home within that whole ACO framework. So we're seeing, it's all about the member experience or the patient experience, as Tom mentioned. We're seeing a big shift into doing more and doing better and being more nimble to better meet the needs of our patients. And that whole dynamic has fundamentally shifted in that type of approach.
Okay, we have one question up here, and this will be the last one. But they'll be here afterwards, so you can maybe catch our speakers on the side.
Yeah, thanks. Tom, you had mentioned that one of the ways you measure value is through engagement and participation. Yourself or any other panel members, anything unique you're doing or more current in terms of trying to encourage or structure the program to achieve more participation and more engagement?
Yeah, so we're leveraging some really neat engagement tools like eVive. eVive is a engagement platform that leverages a lot of information about us to help communicate directly to the member in the way they like to be talked to. And so eVive closes gaps in care, for example, and it knows that I haven't had a colonoscopy, so it'll send me information about how to, not only that I need one, but how to schedule one and within my network. So those tools, I would say the Navigator program, the care coordinator program we put in place is definitely an engagement model. When we first rolled it out, we put a little sticker on the front of the card that said you must call to activate. Like you do on your credit card. It's really not necessary, but it gave people a way to engage in the program. And so we're going to grow that program a little bit more because I just really believe that people need somebody to talk to, right, when they're in trouble. So between eVive and the care coordinator program, I think we have a really good engagement environment to bring about, I'd like to achieve 100% engagement in the plan. And so I think in 2020 with some of the stuff that we're rolling out around those two programs that we'll get a lot more engagement. And I think anytime you can engage somebody and get them to their preventive care, because 55% of the population don't do preventive care, I think you're in a better place. So I'd like to do that. And then we're exploring the opportunity of actually, when somebody has their preventive care, paying for that first diagnosis, right? So people are afraid to get their preventive care in high deductible plans because then they have to pay the deductible if they find something wrong, so they don't go get care until they're really sick. And so we're trying to explore ways to cover that first illness. So I think there's a lot of ways to look at engagement, but I think some tools and resources that are out there today are really cool.
Okay, well, thank you all. Thank you, Riddhi and Jason and Tom, for a really, really great presentation. You set the stage for the rest of the session, the rest of the program here today. We're going to segue right into the very next session, so hang in there for a minute. And everything is tight.